Good evening, sir. Sir, am I audible?
A very good evening to everyone.
Good evening, sir.
Hi, Tushar. Hello.
Good evening, ma'am. How
Yes,
are you?
yes, all good. How are you? How are you? Am I audible, huh?
Yes,
Tushar?
ma'am. Yes, ma'am.
Not,
Yeah, why is Tushar not audible?
yes.
Yes, ma'am.
Uh,
Audible, ma'am.
Okay. I think you received my slide deck also. Now I'll be sharing it from my end. In case there are technical glitches, then you can take it over from your end.
Okay, ma'am.
so I guess we have about 2 minutes. We'll start in some time. So welcome to all Priyanka ma'am and all the esteemed faculties and panelists in this session. Uh, this is designed for all as well as the DM, DNB residents as well as the practicing hematologists across India to where we can highlight all the updates. I hope the session goes it's a big success. Hi Bhavna sir, good evening.
Good evening, Tushar. How are you?
All good, all good. Hi Dr. Kunal, good evening.
Hi, hello. Hi, good evening. Sorry, I'm driving. I'll just join in 2 minutes after parking.
Yes, sure.
Hi,
Hi
Tushar.
Dr. Sadamni, good evening. How are you?
I'm fine. Good evening, ma'am. This
Good
time,
evening. Good evening.
Tushar, this time I'm audible, right?
You are very crisp and clear.
Yes. Yes, ma'am. Yes, ma'am.
Okay.
You're audible.
Okay. ठीक.
Nice to have this initiative. So you do it every Saturday, or is it
Ma'am,
every monthly once
once a month, ma'am.
once a month?
Once a month.
Okay, that's good.
So have all the
Can we
faculties joined?
start the program, sir?
Yes, have all the faculties joined?
Yes, sir. Almost.
Okay, Sanjeev sir, sir, good evening. Sanjeev sir, very good evening.
Good evening, Tushar.
Sir. I
Hi,
think we
Dr.
can start.
Sanjeev. All good?
All good, all good.
Nice, nice.
Okay, team IAIO, please, we can now proceed with the session.
Sure, sir. Good evening, sir. Good evening, ma'am.
I think Sapna, you're not audible.
Good evening, ma'am. Am I audible?
Your volume is very low. You're audible, but it's not very clear.
Good evening, ma'am. Now it's okay. I'm audible.
Yeah, it's not very clear. Can you just check the mic settings once more? Then we can move ahead. This could be a headphone related issue. If you can do it without a headphone, I think it may be more clear.
No, sir. I have not used.
Okay, let me do the introduction, then it's fine. So, without wasting much time, so I would like to welcome everyone in today's expert insights on hemato-oncology. So I'm Dr. Tushar Pandey, the program director. So this session has been made and directed just to bring all the latest evidence-based guidelines and updates when it comes to the management of high-grade lymphomas, specifically DLBCLs, in the day-to-day practice. So before moving ahead, I would like to introduce our guest speakers and faculties. So the session one will be taken by Professor Dr. Priyanka Samal. So ma'am is the professor and head of Department of Clinical Hematology, Hemato-Oncology and Stem Cell Transplantation of Institute of Medical Sciences and some hospital, Orissa. And ma'am will be sharing with us all the updates and in the guidelines as well as in the management of the large B-cell lymphomas. Ma'am, you are welcome.
Thank you, Tushar, Dr. Tushar, for having us over here. And I think in the next 40 minutes or 45 minutes, we will be having a good discussion over it. Would you like to introduce the next speakers and the panelists, or should I continue with the first part?
Ma'am, I'll quickly introduce the other faculties, then we will move ahead, ma'am.
Yeah, sure.
In this session two, we have Dr. Swadhamini Mahapatra, who is assistant professor in the Department of Hematology, Hemato-Oncology, and Stem Cell Transplantation in Institute of Medical Sciences and some hospital, Odisha. And she will be sharing with us a very good case of high-grade B-cell lymphoma, which was atypical, and all the latest therapies, up-to-date therapies were used, and the outcomes will be shared. So, Swadhamini, thank you very much, and you are most welcome. Then
Thank you,
before
Dr. Tushar.
then our experts and faculties as the panelists in session two, I welcome them. And to start with, I welcome Dr. Sanjeev sir. Sir is additional professor in clinical Department of Clinical Hematology and as SGPGI Lucknow, which is an institute of excellence. And we all know all the hematologists follow Sanjeev sir in all his lectures. And I'm very happy that he is here with us today. Sir, welcome. Then we have Dr. Varun Bafna. Dr. Varun Bafna has also been my mentor in my early days, and he is a consultant hematologist, hemato-oncologist, and BMT expert at Star Super Specialty Hospital, Kolhapur, Maharashtra. So you're very welcome. And then we have Dr. Kunal Goyal. Kunal Goyal is lead consultant BMT and CAR-T in Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. He's the head there in the Department of Hematology, BMT, and Cellular Therapies. Welcome, Dr. Kunal. And we have Dr. Fahima Hassan, who is Assistant Professor in Department of Hematology and Stem Cell Transplantation at the Medicity, Uttar Pradesh, United Medicity Hospital, Uttar Pradesh. I welcome everyone, and without further ado, I hand over the session to Professor Priyanka ma'am. Ma'am, please go ahead.
Yeah, thank you, Tushar, for that brief introduction for everyone. And let me share my slides. Mm, yeah, is it visible?
Yes, ma'am, we can see that.
Okay, just a minute. So I'll be talking about the high-grade lymphomas, the evolving paradigms in therapy, including the CAR-T cell therapy, as well as stem cell transplant, where we stand in 2026. So with that introduction, as we just mentioned by Dr. Tushar, the DLBCL is the major chunk of this high-grade B-cell lymphoma, and we have another entity with the translocations. To start with, it is the most common type of NHL, and even in 2026, our CHP remains the backbone of therapy and frontline therapeutic options in the fit patients, with Pola-RG CHP now emerging as the frontline therapy both in the elderly as well as in the uh, fit patients. So elderly, frail or unfit patients may be treated with our mini CHOP or palliation and even Pola-R CHP. Patients with high-risk disease may receive a novel agent with R-CHOP, and we will see what are the evidences and how they have fared, these novel agents, apart from the CAR T cells as well as the bispecific antibodies, which are even now pushed to the frontline therapy in patients who have a high-risk gene expression profiling. So risk-adapted approaches targeting the cell of origin and utilizing interim PET imaging or ctDNA to guide therapy for both escalation and de-escalation still remain under investigation, though we find a lot of trials, clinical trials supporting the evidence regarding how we try to modify our therapy based upon the cell of origin as well as interim PET and the circulating DNAs. So this is regarding the frontline therapy. Then we will have something discussing about the second line therapy. Here again, we have a curative intent approach, including the CAR T as well as the autologous stem cell transplant, depending upon the time of the disease progression after the first line therapy. And in the relapsed refractory setting, though there has been a rapid growth in the therapeutic armamentarium, which include the bispecific antibody combinations with chemotherapy, bispecific antibodies with antibody drug conjugates, and the new incomer, that is the brentuximab vedotin and lenalidomide plus rituximab, which has got FDA approval just in 2026, in the early 2026. We need to understand how do we go about these drugs, or how do we sequence these drugs once the patient has a second relapse or in the subsequent relapses. So that was regarding DLBL. And as I said, high-grade lymphomas with the MYC and the BCL2 or the BCL6 rearrangement is now limited to either nomenclature of DLBL or high-grade lymphoma with the MYC and BCL2 rearrangements. BCL6 has now been taken out of this nomenclature. Whereas the large B-cell lymphoma with the MYC and BCL6 rearrangement is typically classified as DLBL NOS and occasionally high-grade B-cell lymphoma NOS. Burkitt-like lymphoma with 11q aberration is now recognized as different from Burkitt lymphoma, and it is termed as high-grade B-cell lymphoma with 11q aberrations. And apart from that, the high-grade lymphomas where extranodal involvement is also considered to be it is considered to be aggressive in nature. In the immune privileged sites, that is the primary CNS lymphoma, the vitreoretinal lymphoma, and the testicular DLBL, these are something which need to be taken care of as per the treatment of the high-grade lymphoma. But we will be restricting ourselves to the DLBL as well as the high-grade lymphomas. So why do we classify the aggressive B-cell lymphomas again into, morphologically Burkitt, high-grade or the large B-cell? That is based upon the cell of origin and the gene expression profiling. And accordingly, the MYC and the BCL2 as well as the BCL6 rearrangement we just talked about in 2017 WHO classification was considered to be a high-grade lymphoma with these rearrangements which has to be expressed by the fish. And if you look into, this was a distinct entity, but now BCL6 rearrangement has been replaced and it is just limited to MYC and the BCL2 rearrangement, and the BCL6 is considered as the NOS subtype. It is no more regarded as a very aggressive lymphoma as compared to the DLBL NOS. And in the same aggressive category also comes the primary mediastinal B-cell lymphoma. And based upon the cell of origin, whether we have the ABC or the GCB signature, the DLBL NOS both are categorized into one group. So looking into the evolution of the therapy, since we are talking about the changing paradigms in the treatment, for the last 2 decades, if you look into CHOP was first started in 1976, it came into practice. 1997 almost, it was approximately 2 decades later, rituximab, which was the first targeted treatment for B-cell non-Hodgkin lymphoma monoclonal humanized antibody. And there was a major shift in the PFS as well as the OS as compared to CHOP. After that, it had remained in the armamentarium of the treatment of DLBL till I think in 2017 when in India we got the polatuzumab. So R-CHOP became the standard of care with a lot of clinical trials, which set up that rituximab, addition of rituximab has really transformed the overall survival as well as the progression-free survival with minimal toxicity or the same toxicity, and hence it has become the standard of care, and it remains so in countries like India, where polatuzumab is not still affordable and accessible to every patient of DLBL. But having said that, our CHOP, I think, is now the era where we never have given a patient single CHOP without adding R to the backbone. So with that outcomes with R-CHOP in the untreated DLBL, if you see in the frontline therapy, treatment-resistant diseases are much less, and R-CHOP remains fine without increased risk of toxicity. And as I said, the trying to progression PFS as well as OS, there was benefit across all the groups, be it the low risk, high risk, or the intermediate risk group of DLBL. With that, since all the patients who are diagnosed with DLBL, they receive R-CHOP as the frontline therapy, but we find 30 to 40% of the patients still have a relapse. And they are the ones actually, when you go with the second line therapy, are the ones whom you have to think what is the treatment next and what are the things which have played a role in making the disease resistant. So one is tumor heterogeneity. So as you see the WHO classification, there are approximately 15 to 17 subgroups again of the DLBL based upon the genetic signature. So there is a huge heterogeneity in these group of the DLBL patients, be it genetic or the epigenetic changes in the cancer cells, and the expansion of the pre-existing resistant clones in the cells with acquired resistance. So here you can see that genetic modifications in the cell cycle regulation, DNA damage response, TP53 mutation, epigenetic regulation with the EZH2, and the KMT mutations, immune surveillance, some oncogene signaling pathway, as well as the DNA methylation as the histone methylation, all of them have a genetic and an epigenetic alterations and leading to tumor heterogeneity. This was regarding the tumor signature. Next is the microenvironment. So immune dysfunction and the supportive stromal cells promote a pro-tumor environment for tumor resistance. And as you can see, and as we understand, this is the era of cellular therapy, and we are diving more into the aspects of T cells, NK cells, the stromal cells, as well as the mesenchymal cells. All of them, actually, the tumor microenvironment definitely has a very important role to play in the tumor disruption, the resistance to the therapy, as well as relapse. So this results in inadequate apoptosis. That means the tumor microenvironment is trying to allow the tumor cells to escape rather than undergo a hit by the therapy. And that occurs because of the dysfunctional immune microenvironment. Then host variabilities. Interpatient variabilities represented from multiple host-specific factors which lead to variable responses to therapy. And as we know that the elderly people, they have a lot of as such mutations, or they have comorbidities because of which they are unable to tolerate therapy, or else the therapy is less effective in them. Then there are pharmacokinetics within each individual, and therefore the metabolism might be different. So these are the problems which results in the relapse or the refractoriness of the disease, and there are also some SNPs which are host factors seen in these patients. And we talked about the tumor microenvironment, the stromal cells as well as the follicular dendritic cells. They prevent the tumor cells from undergoing apoptosis. So now there is a lot of talk regarding the circulating tumor DNA, even in the hematological malignancies, and this concept was first actually more prevalent, and now even I think in the practice by the medical oncologists, the circulating tumor DNA in the solid malignancies now they are looking into the measurable residual disease with the ctDNA. Similarly, in lymphomas, the ctDNAs have been considered in some of the trials, and especially in the Polarix trial, which is now coming up with the updates where they are quantifying the measurable residual disease with circulating tumor DNA, and it has been found to be more sensitive with a 10 to the power minus 6 sensitivity as compared to the interim PET or end of therapy PET for the patients. So here you can see the patients who had less of circulating DNA, they fared better with a better PFS in this red line as opposed to the patient who had circulating DNA in their cells, in their blood. So ctDNA has prognostic value for patients with newly diagnosed DLBL. Early changes in the level of ctDNA may be of use of risk-adapted trial to identify those patients who are in need of alternative treatment. So if the ctDNA at the end of therapy is quantifiable and the patient is having a measurable residual disease, we may think of consolidating the patient either with a CAR T or with autologous stem cell transplant, even in a frontline therapy. So this was phased variant enrichment and detection sequencing, ultra-sensitive ctDNA detection method, and this improves the outcome prediction at interim time points in DLBL. So these are all in clinical trials and they have not been considered as, the presently the guidelines how to assess the patient at the different time points, like interim post 3 cycles of the DLBL or end of therapy DLBL. But definitely in the coming years, we will have a lot of data supporting this, and possibly this might be a standard practice in the coming years. So log fold change in ctDNA by cycle 3 measured by the SNV based methods. So these are based upon the sequencing, and the event-free survival in patients with DLBL who were ctDNA negative, you can see how the line has almost, there is a 90% EFS as you see in this curve. And then you have another EFS for these 52 patients with the stratified ctDNA detection. The patients who had not detected ctDNA had a better survival as compared to the patients who had detected ctDNA at the end of cycle, at the end of therapy, as seen in this graph. So PFS in the patients with DLBL treated with R-CHOP, according to the rearrangement by Fish, as we just mentioned, that there are two types, the cell of origin where we say it is GCB type or the non-GCB type, and a better way, like the MYC as well as the double hit and the triple hit lymphomas. You can see that the MYC negative are the ones who fare a little bit better than the ones who have MYC double hit as well as the single hit MYC positivity. Then something regarding the double expressor lymphoma, overexpression of both the proteins, that is MYC and BCL2 proteins as measured by IHC, occurs in approximately 30% of the DLBL. It is a poor prognostic feature, not a unique biological entity seen in the GCB as well as the ABC type, but we find it more common in the EBC type. Alternative treatment is not recommended for this patient as preferred therapy is not identified. So this is for the postgraduates or the DM and the DNB students, the double expressor lymphoma you need to look into at the IHC, but they do not actually, there is no recommendation to go for a aggressive therapy rather than R-CHOP for this group of the patients. So prognosis according to the cell of origin by the gene expression profiling. This is how the gene expression profiling looks like. Presently, approximately there are 113 genes which they are looking into, even for the patient of the DLBL. Prognosis 15 to 20% difference in the 3-year PFS between the GCB and the ABC subtype. So you can understand that why we need to separate these two entities. And as we discussed, the ones which have ABC type, they are poorer as compared to the GCB, that is the red line over here. And the Goya trial, where they have used actually obinutuzumab with with CHOP versus R-CHOP. And here you can again see that the GCB fares better even if we are changing Gazyva or obinutuzumab as compared to rituximab. So there is no added advantage of using a drug which is more costly, but still you will find that the group which is GCB fares better in whatever be the drug in the frontline therapy. So I think there are approximately 115 genes which have been identified, and these are all the genetic features or the genetic signatures of the patients having different type of DLBL. So this is what is the crux, and now I think we have a lot of data supporting the genetic subtypes. Here you can see the DLBL, the whole group, gene expression subgroups ABC, unclassified GCB. This is what is broadly classified into. And the genetic subtypes, this is MCD is the mixture of, that is the presence of both MYD88 L265B mutation as well as CD stands for the CD79B mutation. So that is known as MCD. N1 is Notch1 mutation. A53 is TP53 aneuploidy. BN2 is BCL6 and the Notch2 mutation. ST2 is STK1 and the TET2 mutation. MYC plus. And this is again, if you look into EZB, that is EZH2 and the BCL2 translocation. And with that, if there is a MYC translocation, it is known as MYC plus. And with this combination, if you do not have that, it is known as MYC negative. And within the MYC negative group, you have these two mutations, CARD11 and the TNF AIP3 inactivation. And the composite ones are when you have a mixture of all these mutations. So why this is important? Why they are trying to look into the hallmark genetic features? So overall survival with R-CHOP and the chemotherapy, if you see the 5-year overall survival is 84% and 82% with the EZB and the ST2 mutations. These are the favorable mutations, and it is worst with Notch1 mutation and the MYD, that is MCD or the MYD79B mutation. So these are the ones which fare poorer. So if this is the thing which happens with R-CHOP, to increase this overall survival or the PFS to 80 or 90%, do we need to add some second drug or a targeted therapy looking into the type of mutations where we can target or hit these mutations? So in the first group, you see where it was 40%. If you add a BTK inhibitor, phosphatidyl inositol 3 kinase inhibitor, BCL2 inhibitor, or a JAK inhibitor, or an IRF inhibitor, then possibly there are trials going on. We still do not have robust data to support, but looking into the type of the mutation, these are the targeted agents which can be added to the R-CHOP backbone in order to increase the overall survival. The Notch, again, BTK has a role, TP53, BTK inhibitor, you know it from the CLL itself. And from for the BCL6 and the Notch, you can have the first three BTK, phosphatidyl inositol 3 kinase, as well as BCL2 inhibitor. And similarly, for the other two subgroups, these are the drugs which can be added as a target therapy in order to push up the PFS or the OS of the patients or the efficacy of the regimens. So having said that and looking into the genetic signature of the DLBL, however, in 2026 also the treatment algorithm for DLBL remains the same. That is, you perform a FISH for the MYC and the BCL2. If it is a double hit and it is a fit patient, dose adjusted epoch R is the therapy which we are using as of now for clinical in our clinical practice, and clinical trials have very well supported that a more aggressive therapy than just R-CHOP has to be given to these patients. However, if these patients are unfit, you can try with R-CHOP in the first cycle, and the tolerability, if the patient's tolerability is better after R-CHOP, you can even switch over to dose-adjusted epoch-R in the later cycles. For DLBL, R-CHOP remains the treatment of choice. So this is the update, 2026 update. This is what we talked about. For the unfit and the elderly patients, our mini CHOP can be given. Despite our growing understanding of biology, we continue to treat patients with DLBL same, and this remains the standard of care. So these are the different trials where we have compared R-CHOP 14 versus 21, and nothing has been better than R-CHOP. Apart from in 2011, where RCBP was given to patients who were less than 60 years, and there was some sort of a better therapy, but then it comes with toxicity. So that also does not, it is also not the standard of care. Then there were some trials on maintenance as well in the patients of DLBL, where rituximab, lenalidomide, everolimus have been used, and you can see there were no benefits even when the maintenance was given in this patient. So as we talked about, there was a subgroup of ABC where NF-kappa beta activation has been there, the pathogenesis has shown that there is NF-kappa beta activation, and therefore to hit this pathway, we had bortezomib, lenalidomide, and ibrutinib, and these were the trials: remodel trial, the robust trial, and the phoenix trial. However, you can see better than R-CHOP, none of them. Lenalidomide and R-CHOP, there were some of it, but it was again a phase 2 trial. And lenalidomide also had some secondary malignancies on the long-term follow, because of which lenalidomide was again dropped out from the main therapy backbone. So the new kid on the block is polatuzumab vedotin. You know the mechanism of action. It is a microtubule inhibitor, MMAE, that is conjugated to 79B monoclonal antibody. And you can see over here, this is the polatuzumab attached to it, binds to the CD79B. It is internalized. Microtubule disruption happens by the MMAE, and then the cell undergoes apoptosis. So 2019 FDA granted an accelerated approval to Pola in combination with BR product for patients who were relapsed refractory to DLBL after more than equal to 2 prior line of therapies. So that was how it got approved. And then we have in the upfront or untreated DLBL, Pola RCHP versus RCHOP. This was a multicenter double-blind, the Polaric study, phase 3, 18 to 80 years of age. Primary endpoint was PFS, secondary was EFS and CRR at the end of treatment. These were the disease characteristics. And if you look into not a very great significant difference, the p-value was 0.02, PFS 2-year PFS was 76 versus 70, and EFS was also not very significant. The hazard ratio was 0.75. Subgroup analysis, you see over here, it is almost like Pola RCHP was a little bit better, but if you look into the GCP group fared well, but not the ABC type. The younger patients were a little bit better. Females, IPI more than 2 was better. Bulky disease was better. Double hit and triple hit was also a little bit better. But however, the significance was not very well if you look into the p-values. So the patients receiving in this group, this is the R-CHOP versus the Pola RCHP, that is the blue one. Here you can see any treatment further received was more in the R-CHOP group. Radiotherapy also more patients required because at the end there was some amount of residual disease. Systemic therapies also more with the R-CHOP. More patients went for the SCT or the CAR-T because there were more amount of relapses following R-CHOP alone. So peripheral neuropathy is something because it is a microtubule disruption with the Pola vedotin. Peripheral neuropathy is one of the known side effects, and febrile neutropenia. Here you can see with Pola RCHP it is 14 or 13% any grade as compared to 8% in R-CHOP. So these are the two things we need to keep in mind. So looking into the data of the Polarics, is Pola RCHP the new standard of care? You looked into the graphs where the differences were not very high. Should it be used in all patients regardless of IPI or COO? And what about the limited stage protocols? We saw that stage 4 higher IPI fared better. So should it be also the standard of care for the patients who had limited stage disease? And should Pola RCHP be the comparator in all clinical trials, like the way we talked about whether to add upon based upon the genetic signature? So looking into the Pola RCHP Polaric trial, my take was safety is well established, yes. PFS benefit is small but meaningful in a group of patients which are high risk. No benefit in the GCB, so it is better that you can go ahead with the R-CHOP as well or the double hit. Benefit more in the ABC subtype, and FDA approval in April 2023 for the frontline therapy for DLBL and the high-grade B NHL with IPI 2 or higher. So the patients who have limited stage disease, you may not push with the Pola RCHP. And this was in the ASH last 2025. You can see transcriptional profiling redefines DLBL classification and identifies the subtype. In the Polarix trial, those groups also have been taken up, and retrospectively they have been again subdivided into the based upon the genetic signatures which we just talked about, and they looked into how the subgroup of the patients have fared. So the conclusion there was DLBL is highly genetically heterogeneous. The lymph gene captures genetic heterogeneity better. Signature of the lymphoma expands the subtype assignment to previously unclassified DLBL, identifies the MCD signature as a predictive biomarker, just as I had shown the earlier cartoon over there, the MCD, that is MYD88 with CD79B, it had a lower survival as compared to the overall survival as compared to the other subgroups. So they have found that it is a predictive biomarker for POLA RCHP benefit. So transcriptional profiling meaningfully refines the precision therapy in DLBL. So touching into the other therapies which are available or the trials which have been there, acalabrutinib with R-CHOP in untreated DLBL. Here again, the primary endpoint was assessed as the PFS. Then tafasitamab, which is a monoclonal antibody targeting CD19 along with lenalidomide and R-CHOP, 1 to 6 cycles as opposed to tafasitamab and tafasitamab given in the as compared to the comparator arm where tafasitamab was replaced by placebo, and end of therapy follow-up for approximately 16 months was there where they are trying to look into how this drug in the upfront, whether the CR rate as well as the PFS rate is increased. Then we have epcoritimab with R-CHOP in the untreated DLBL, another new drug. This is a bispecific antibody CD3 and CD20. Innovative trial designs, as I said, BN2A53, that is with the TP53 mutations, and these are the 5 clusters now on the molecular subtyping where POLA RCHP is the backbone along with the new agents which are X, which we just discussed regarding how the BCL2 inhibitor, then we have the proton kinase inhibitors, they are being added, and these results are yet to be published to see whether with the POLA RCHP we can add something to have a better outcome. We again had this ASH 2025 zanubrutinib in combination with R-CHOP. Again, the MCD subtype have shown, which has a poor outcome, has shown better results with zanubrutinib along with the ones who have TP53 mutation positivity. Here you can see ORR is 92%, CR is 87%, and the non-GCB group CR rate is 91% as opposed to the other trials where they have shown that the non-GCB has approximately a CR rate of 60 to 70%. So that was regarding DLBL in the upfront therapy. This is the second part of the talk. I will rush through it. High-grade lymphomas, relapse refractory placing. Where do we place CAR-T and the stem cell transplant? So as we know that early relapse always has been associated with very poor survival in the DLBL, and it is across all the trials. And even if you use Gazyva in the front line as opposed to R-CHOP, still survival if it is if the relapse is early, it doesn't make a difference and it remains as a poor disease. So these are the unmet needs and the treatment gaps. You know that second line therapy, 32% of the patients will not be able to afford therapy or will not be in a condition to take the second line therapy. Third line therapy still it goes lesser. The key management, whenever you are having a patient of a DLBL, do repeat a biopsy to see, look into whether the patient still has DLBL or it has transformed to some other lymphoma. And apart from that, you need to look into whether there is CD19 as well as CD20 positivity is there, because most of the time there might be also an antigen loss or a suppression. CAR-T and the bispecific antibodies have to be targeted based upon the presence of these markers, and that is how it guides the next line therapy. Therapeutic landscapes, we have CAR-T, bispecific antibodies, chemotherapy-based salvage, which is still something which is doable in India, followed by an autologous stem cell transplant. And even in a refractory setting or a relapse setting, look into the cell of origin, and that is because whenever you are trying to prognosticate or when you are trying to choose a therapy, then we have to look into what is the cell of origin in the relapse also. So these are the approvals for relapse refractory DLBL in the last 5 years, where in 1997, as we talked about rituximab, and after that 2017, so it is approximately 3 decades later, we have the CAR-T bispecific antibodies as well as the bispecific antibodies as well as the targeted therapies like the polatuzumab and the brentuximab. So integrating CAR-T therapy into the management of DLBL. So second line therapy we have, you see after the progression will determine what is the type of therapy you want to offer to the patient. Progression is less than 1 year. CAR-T eligible, go for CAR-T as the second line therapy. Progression is more than 1 year and auto transplant ineligible, CAR-T ineligible, then you go for the bispecific antibody with a GEMOX backbone. You have mosunetuzumab, olatuzumab together with the BR. And if it is more than 1 year and auto-SCT eligible, still salvage chemoimmunotherapy followed by autologous stem cell transplant is the therapy option you have to think about. And then we have the CAR-T therapy where you can just mix and match whether the patient was exposed to CAR-T followed by ASCT or it was first ASCT where you can use CAR-T or a bispecific. So this is what is the outcome of the conventional therapy for relapsed refractory DLBL, and you can see over here it is nothing more than 20%. So you have to go with the newer therapies like the CAR-T. So we have the Axicel data. In India, we have Dr. Kunal over here saying about the Nextar 19, which is from India, but here we have the Juma, Juliet, the Transform, Transcend, and the pilot trial, where Axicel, Tisacel, and Isocel are the ones which have been used and have the highest, longest follow-up data with very good overall response rate ranging from 80% to approximately 85%. And the survival and the follow-up has been now 5 years post these CAR-T therapies. So survival you can see across all the three types, that is Axicel, Tisacel, and the Lisocell. Almost the graphs are similar as when you look into the PFS and the OS survival. So for the high-risk DLBL in early relapse, that is within 12 months of the first-line therapy, the salvage chemotherapy followed by autologous stem cell transplant is questionable. Do not try to push the patient to a auto transplant, but try to keep CAR-T as your second-line therapy. And this remains the standard of care as of now for patients who are affordable. So fitting CAR-T therapy into current treatment paradigms, just we discussed initial chemotherapy, primary refractory CAR-T therapy. Still not, the patient is not able to afford the CAR-T, you can go with the salvage platinum-based therapy followed by an auto transplant. So avoid, what are the things you need to keep in mind when you are preparing a patient for the CAR-T? Avoid therapies that cause severe T-cell lymphopenia because we need the T cells to genetically engineer them for the CAR. Unknown impact of prior CD19 directed therapies, stop novel agents like ibrutinib or lenalidomide prior to infusion. Bridging therapy sometimes is needed if the patient has a high tumor load in order to decrease the CRS. Lower disease burden is equal to lower toxicity, yes. Look into the CNS involvement. If there is a CNS involvement, it is better to go with the CAR-T because it has a better penetration. You can use as a lymphodepletion fluci, that is most common. And there are papers on bendamustine as well. Rule out active infection and check the HIV status. Though HIV status is there, you need to monitor the CD4 count to see whether there will be any activation of the secondary infections. So treatment in the DLBL in the third line setting, where when the patient has already opted out from the CAR-T as well as the auto transplant the patient has been exposed to. So POLA BR indication more than equal to 2 prior lines. Accelerated approval had been there. Tafasitamab and lenalidomide is again a bispecific antibody with lenalidomide. Here you can see that rituximab you may use, you may not use. That was the comparator arm over there in that trial. And indication is again patients who are not eligible for ASCT. Lonca cetuximab, that it is indicated for more than equal to 2 prior lines, and selinexor. Though selinexor is an oral drug, but it is very difficult to manage the toxicities of selinexor. Therefore, it is much down where the patient has already failed 3 to 4 lines of therapy. So Polarix trial, you know about that. Bendamustine rituximab is the drug where a patient who is not eligible for CAR-T or not eligible for auto-SCT can be used as a BR backbone. And you can see the PFS was much better than the patients who had received just BR. Well-Mind trial where tafasitamab and lenalidomide have been used. Again, the PFS and the OS, you can see with the red curves, much higher than the ones where the patients have not been given this drug. Neutropenia is something you need to look into for those patients. Lonca for the patients, for relapsed refractory patients, again, in these patients who have had third line therapy, for them even a PFS of 4.9 months is definitely something you are offering to a patient who is having a normal relapse-free survival of approximately 1 to 2 months. So selinexor, I said, it is a good drug, orally available, but very difficult to continue the therapy because of the numerous side effects. So sequencing CD19 therapies, patients with DLBL may retain CD19 expression after LONCA therapy, median interval between LONCA and CAR-T at least 120 days. So because the T cells have to be, they have to go and attach to the CD19, therefore the median interval should be good enough for the cells to again re-express the CD19, and its expression should be tested by IHC. Response to CAR-T therapy is approximately 50%. Preliminary studies, prior CD19 targeted therapies do not preclude later use of CAR-T cell therapy. So guidance, as I said, look into the patient's characteristic, the baseline therapy or the number of lines of prior therapy the patient has been exposed to, and then do the combinations. So this is my last slide where, as I said, brentuximab has got a FDA approval in February 2025, and even in India, it has got an approval now for the relapsed refractory LBL. What is important over here is to note that it has the same mechanism of action as that of COLA, and patients who have less than 1% CD30 expression, it has been shown to have efficacy even in those patients, and therefore just look into what is the key take-home messages from this study. It is approved by FDA for the treatment of adult patients with relapsed refractory LBL, including DLBL, NOS, DLBL arising from indolent lymphoma or high-grade B-cell lymphoma after more than equal to 2 prior lines of systemic therapy, who are ineligible for auto-HCT or CAR-T therapy. Primary mechanism of action, CD30 expressing tumor cells and similar to that of COLA, where it induces apoptosis. Results of the Echelon 3 trial show that BV plus R2, that is rituximab and len, in 3-line or later is associated with survival benefit. And the post-hoc analysis suggests that visible CD30 detection by IHC less than 1% versus no staining is not required for response of BVR2 in patients with relapsed refractory DLBL. Taken together, these findings support the use of brentuximab plus R2 in heavily pretreated patients of relapsed refractory DLBL, irrespective of visible CD30 expression by standard IHC. So this is something you do not have to look into what is the percentage of expression, even 1%, even if there is a single cell positive in the full CD30 stained slide, still the patient suffices to get the benefit of this drug. So that is what is the summary. And with that, I will end because I think I have already crossed 15 minutes. Thank you.
Thank you, ma'am. Thank you for your insightful presentation. So now we move on to the panel discussion. I would like to invite the moderator, Dr. Saudamini Mahapatra, and along with him, I also welcome panelists, Dr. Varun Asok, Dr. Kunal Goel, Dr. Fahima Hassan, Dr. Sanjeev. Now I would like to hand over the moderator, Dr. Saudamini Mahapatra. Over to you, ma'am, please. Am I audible, ma'am? Am I audible, ma'am?
So Damni, we cannot hear you. Can you hear us?
Yeah, yeah. Sorry, sir. There was a technical glitch. Is my
Yes.
screen?
Yes, please proceed. Please proceed.
I audible also? Hello.
Yes, ma'am. Yes, ma'am. Audible, ma'am.
Yeah. Okay. Good evening. Thank you, Dr. Tushar. Thank you, the AIO team. And I think good evening, Varun sir. Good evening, Kunal sir. Good evening, Sajid sir. And good evening, Faima ma'am. Let's proceed with the case. So, a 48-year-old male, Mr. M, native of Odisha, presented to us with a bilateral chief complaints of bilateral pedal edema for 4 days, abdominal distension for 4 days, decreased urination and passage of stool for the last 4 days. On examination, his vitals were stable. He only had pallor and bilateral pedal edema extending up to the ankle joint. On
Dr.
per
Sadamani,
abdominal,
we cannot see your slides on the screen. Only your first
um,
page is visible. Have you turned the screen? आप
I
slide show
was
on कर दो एक बार.
sharing.
Slideshow is on.
Huh? Huh? Abhi?
Can you switch on the slideshow?
Is it moving?
No. I think slideshow is not
Uh,
on.
No, it's on, but I think the team can proceed from their side, right? Hello?
Yes, Subhashri,
Hello?
kindly look into the English.
Yeah. Subhash, you can share from your side, right?
Yes, yes. Yes, ma'am.
Okay. Is it moving right now? Hello?
It's-
Is it moving? Hello?
No, it's not moving, Sadamani.
Subhash, you can play from your side, right? Yeah.
Yes,
Go to the
ma'am.
previous slide. Yeah. Okay. On the previous slide. Okay, so the history was a 48-year-old male, Mr. M, native of Odisha, presented to us with the chief complaints of bilateral pedal edema for 4 days, abdominal distension for 4 days, decreased urination, and a passage of stool for last 4 days. On examination, his vitals were stable. He only had pallor and bilateral pedal edema extending up to the ankle joints. On per abdominal examination, the liver spleens were not palpable, but there was an irregular mass present over the lower abdomen, measuring around 5 into 4 centimeter. Whereas the other reticular lymphocyte system, we have small bilateral axillary and cervical lymph nodes measuring about 1 into 1 centimeter, and the chest and the CNS were within the normal limit. Next slide. If we go back to the past history, he is actually a known case of high-grade DLBCL diagnosed in March 2023 outside and was started on RCHOP. He has completed 6 cycles of RCHOP in September 2023, and end of the therapy he was in CMR, and then he was lost to follow for 3 months. But after 3 months in Jan 2024, he had an early relapse and he was given 3 more cycles of RCHOP. But post 9 cycles of RCHOP also, he was a progressive disease. And in April 2024, he was shifted to RICE, given 2 cycles. But still the disease was progression and then shifted to B plus R. Next slide. He didn't tolerate it well the B plus R. Then he was shifted to CEOP, and in between also he received some image guided radiotherapy, followed by the continuation of the RCEOP along with the stereotactic body radiotherapy to the right chest wall mass in July 2024, and completed 6 cycles in September 2024. But still at the end of the therapy, it was a progressive disease with an extension even into the IVC, leading to the thrombotic occlusion. And with this, he presented to us. Next slide. When he presented to us, his we did a complete testing again, investigations again, and his hemoglobin was 10.6 with a TLC count of 6,000 with neutrophil predominance and a platelet of 1,28,000. The LDH was raised; it was 1,100. The creatinine was 1.40. Uric acids were 4. Other parameters were within the normal range. We did a bone marrow also just to see whether there is infiltration or not, but there was no infiltration. We repeated a biopsy from the retroperitoneal lymph node, and it was suggestive of the DLBCL. Next slide. So we made a diagnosis of early relapse refractory DLBCL stage 4 BXE with IVC thrombosis, RIPI score of 3 points, which belongs to the high intermediate risk group with a overall survival of 55% and a CNS IPI of 3 points. Next. With this, I would like to ask the panelists what will be their approach for such case. Varun sir, can you take the question? Hello? Varun sir? Kunal sir?
Hi. So in this case, the patient is high risk, early relapse. In that condition, we can still go for autologous transplantation in the era of CAR-T, provided you have a complete metabolic and morphological response to the salvage regimen. There is a data and paper from Sadman et al. When they have showed that even with the autologous transplantation in high risk, when you have complete metabolic and morphological response with CAR-T, you can still have a good response as compared to CAR-T or equal to CAR-T. But in most of the cases, this thing is less likely to, you know, it's not that easy to get a complete metabolic and morphological response. The patient also have a high CNS-IP score, a intermediate score. So I would also look for the CNS status as well before treatment. But in case he had some CNS involvement as well, which is occult, as there is no symptom in this case. So I still go for a good salvage regimen with the combination of immunotherapy followed by assessment of PET scan, followed by decision of a CAR-T. Meanwhile, I will tell the patient that this patient may need a harvest for CAR-T as well. And after CAR-T, maybe a maintenance in some of the cases selected ones.
Okay, sir. So, Subhashi, next slide.
Yes.
Yes, so we also followed the same protocol. It's just like ma'am also said that it was an early relapse less than 2 months, 12 months, and it's also like a refractory case. And he was at CAR-T eligible. We also tried for CAR-T therapy before salvaging the patients. Next, what? Subhashi, next slide. These are some of the regimens which we could have followed. Yeah, go to the next slide. Actually, for this patient, we have planned for glofitamab on a compassionate ground. So we planned a therapy of glofitamab plus polatuzumab. Next slide. Subhashi, next slide. As we all know, back. As we all know, glofitamab is a bispecific with an overall response of 47% with a median OS of 5.7 months and median PF of 3.6 months and with a less CRS and ICANS in infection. So we planned for this drug. Next one. Next. Actually, there was some delay in getting the glofitamab. So in October 2024, we gave him the first cycle of polatuzumab vedotin plus rituximab, and also we started him on rivaroxaban for IVC thrombosis. But after 10 days, he presented with upper GI bleed and melena. Next. We did a CBC. CBC was absolutely normal. The platelets were in the normal range. We did an ultrasound abdomen, which showed moderate ascites. Next. With the help of FFP and FFP transfusion, we did an ascitic typing and sent it for the cytology. The smear was cellular and predominantly the mononuclear cells were seen. Next. We ran a culture which didn't show any type of growth. We also tested we also tested for the TB. The AFB were negative. The ADA was in the 22. LDH was 684. The biochemistry showed sugar of 78 and a fluid protein albumin of 2.39. Next, the SAC score was 0.4, which was going in favor of exudative. So we did run a flow cytometry. We didn't show any evidence of clonal B cells. Next. 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 So, sir, I would like to ask, what is the drug of choice for cancer-associated thrombosis in your practice? Dr. Faima or Dr. Varun? Sir, can you take the question, Kunal, sir?
Hi. So in these cases, apixaban appears to be valuable and effective lesser chances of bleeding as compared to rivaroxaban, especially in the GI involvement. So I would have used rivaroxaban, apixaban in these kinds of cases, and I think this is my take for this.
I think
Okay, so
and we
actually,
can also take Sanjeev
So,
sir's take on the
Sanjeev sir.
same. Sanjeev sir, if you could add on.
Sanjeev sir.
Yes, for cancer associated thrombosis, there is a famous Caravaggio trial which has clearly shown that apixaban is a better molecule for cancer associated thrombosis rather than any other DOACs, while the previous standard of care is the low molecular weight heparin. So either low molecular weight heparin or apixaban will be ideal anticoagulation in this case rather than rivaroxaban.
Okay, sir. And in case the patient is on DOACs and bleed, then some management will be.
Uh, Basically, there are specific inhibitors for DOACs associated bleeding, but if it is not available, FFP can be used for that purpose, and we can switch to low molecular weight heparin.
Okay. Yes, sir. We did the same. Subhashi, next. We stopped the rivaroxaban, transfused the patient with FFP, and under the albumin coverage, we did the therapeutic tapping. And after stabilization, we started the patient on a low molecular weight heparin. Next slide. Like Sanjeev sir and Kunal sir had said, there has been an article published in NEGM in March 2026, which has shown that if in apixaban there is a low risk of bleeding, so it's better to opt for apixaban. Next. And due to logistic issue and there was some delay in getting the glofitamab in the month of November, we had given the patient a cycle of RGDP, and during that stay he developed some pneumonia, and upper GI bleed and melena was again a problem. So we managed the patient with the antibiotics, and anticoagulation was stopped for some time. Supportive care was given. Then he was after stabilization he was discharged, but after 15 days the patient developed a high grade fever and presented to us with pancytopenia and was diagnosed with that as dengue fever with HLH with upper GI bleed, because of which we have started him on Solumedrol 1 gram for 5 days, followed by the oral steroids, and was along with the supportive cares. Almost like he has to stay from 20 days in the ICU and in the hospital. Then he was discharged after stabilization, but again in the month of December, he presented with abdominal distension and bilateral pedal edema. Next slide. We did an ultrasound abdomen. It again showed a gross ascites with minimal pleural effusion. The upper GI endoscopy showed a diffuse mucosal ooze with an or esophageal candidiasis. Ileocolonoscopy showed rectal and colonoscopic superficial ulcers with internal hemorrhoids. Next slide. Subhashi, next. After stabilization, FFP and platelet transfusions were given, but this time we have got the glofitamab. So he was given obinutuzumab 1000 mg on day 1, polatuzumab on day 2, then glofitamab on day 8 and day 15. Next. Then after 3 weeks, when we repeated the PET scan, this time the patient was in remission. The PET scan showed a favorable response. Next. But the problem was that patient was recurrently having ascites. Albumin has been infused twice for the for hypoalbuminemia. We have to do the ascitic tapping 6 times in 2 months. He was multiple time tested for the TB, but it was coming as negative. He was repeatedly presenting with the ascites. Next. Sir, I'd like to ask, would you like to start empirically ATT in this type of patients? Sanjeev sir?
Very unlikely, unless otherwise we have an evidence for tuberculosis. Um, Probably I will not start the ATT, but will definitely like to investigate for this recurrent ascites that patient is having, whether liver is okay or not, any fibroscan
Sir,
or
actually, we did that one. We repeated the CT scan, and every time liver was okay. And even we did tested the all the cytology and everything, biochemical and everything. It was going in favor of exudative. We have run the flow cytometry in the ascitic tapping also multiple times, but it was coming as negative actually.
okay.
So because This is an endemic country. We have, next slide, Subhashri. We have, with a strong clinical suspicion, we have started give him a therapeutic challenge of ATT, and to the surprise, within 2 weeks, actually, patient's ascites came down and patient was clinically improved. So for that reason, actually, we continued him on ATT.
Okay.
Next slide. Then in Jan 2025, as the last PET showed that it was in remission, we go for the T cell apheresis, and the sample was sent for the processing. Because of the logistic issues, in the month of February, we have given only the single agent glofitamab. Pola was omitted. Next. Then in the month of March, with a flu-style lymphodepletion protocol, we did a CAR T infusion on 12th March, and lymphocyte infused was around 100 ml, which was a dose of 5 into 10 to the power 6 per kg. During his stay, the issues we faced were CRS of grade 1, hypoalbuminemia, and pedal edema. Otherwise, it was an uneventful procedure. Next. So on day 28, when the patient's counts were also recovered, he was absolutely normal, absolutely stable. We have discharged him on ATT and low molecular weight heparin. Next. So, sir, I'd like to ask all my panelists to share the experience with the CAR T therapy and what are the complications they are seeing in their routine practice. Kunal, sir, if you can take the question.
So, there are lots of different types of complications with different patients. Some of the patients may develop ICHS and prolonged cytopenias. Some of the patients we have seen developing tuberculosis after 6 months after CAR T. These some develops some various infectious complications. Most of the time, you will see immune-related cytopenias and ICHS. In the acute phase, we generally see those patients who are prior exposed to ADC, they have a higher chances of liver dysfunction, especially in the along with CRS or maybe with IECHS. And if you continue to monitor the ferritin in these cases and with good supportive care, you can bring these kinds of patients, as you have shown in your case. The patient was very high grade lymphoma, treated well with glofitamab, in fact, with HLH. In spite of being developing HLH in the previous admissions with, he had successfully underwent with glofitamab. So tumor reduction is very important in this condition. When the patient, here I think the CAR T is done as a part of a consolidation CAR T, right?
Yes, sir. Yes,
Not
sir.
the treatment related. So the disease was very much in control, and I believe he has completed 1 year. So in
Yes,
that
sir.
case, how many IPIG have you given to this patient?
Sir, IVIG, I think in day, next slide. Sir, sir, actually, I think day 30, we have, day, sir, actually, day 30, we have not given, but in day 60, we have monitored the IG level. There was some drop. I think 2 cycles of IVIG we have given, but still on day 90, he had CMV reactivation with the CMV DNA copies in 1 lakh. So for that, he was again admitted and managed with the ganciclovir.
Right. So one more important thing regarding the with CAR T, you have CMV when you are treating with ICHS or the prolonged cytopenias or immunological complications. So uh, there is a very higher chances of CMV, and this CMV can further cause HLH and all. There is a a circle,
Yes, sir.
and
Actually, when he
so that
presented, he
develops
directly
this
landed up
cancer.
in actually ICU. He
Right.
presented very badly, actually.
Right. So the patient develops CRS and IECHS, and then during the treatment, they develop CMV. And then if you treat CMV, that's fine. If they develop severe complication of CMV, then there is a downward spiral. So the identification is the key, early identification of all the toxicities and anticipation of treatment, along with good supportive care, including antiviral, antifungal. This is what I felt during all the courses of CAR T that we have seen. And now, I have done just completed my CAR T in an OPD basis on a 67-year female. And she is right now attending her niece marriage in some other place. And till day 28 is not yet done. And she is literally doing very good, even with the retroperitoneal mass of 15 centimeter at the baseline. So there is a good kind of presentations, and although she had developed ICHS, but she was even ICHS grade 2 was managed in OPD with ruxolitinib and small doses of DEXA, that is 4 mg/bt. So total of
Sir,
26 mg she has
actually,
received till now.
how frequently you go for IVIG infusion in your CAR T patients actually?
So we generally follow a dictum when there is a less than 400. We generally give, irrespective of fever or nothing, or any symptoms if the patient have. If it is more than 500, I generally wait and see if even after 500 the patient have recurrent infections. I invariably give IVIG to these patients. Important is we need to prevent infections, especially the viral infections and other complications. So prevention is the key for successful CAR T, that I believe. So this patient didn't develop any kind of CRS till day 10.
He had
At
no CRS grade 1, sir. CRS grade 1.
No. I'm talking about one of my OPD patient
Okay,
regarding
okay,
that
okay.
experience. So
Yeah.
till day 10, she didn't develop any kind of CRS, any kind of this. When at day 12, the CAR T proliferation was at peak, she developed mild grade fever, and considering her higher disease burden, we have given anticipatory tocilizumab with first fever, and when procal and everything was checked, it was negative. So that subsided her another spike of CRS. That controlled single dose of CRS was controlled. Day 21, she developed cytopenias from 3 lakh count to 50,000 in 3 days platelet count, with ferritin doubling in almost next 4 or 5 hours. We have given her started on ruxolitinib 5 mg BD with small doses of steroid. In next 1 week, her counts and everything recovered. Everything is on the OPD basis. No,
That
nothing
means like
admissions and
the
everything.
first spike of fever, it's like you go for toci directly or any steroid or something you go along with that one.
No, I don't give
Directly
steroid
toci.
when the disease burden is very high and you
Okay.
are certainly sure that this is not an infection. You do literally do biofire in the OPD basis to rule out any infections, and then you can go ahead with this. So, OPD basis, if you are anticipatory, you can anticipate what are the possible complications with more and more CAR T. You can understand. So it becomes very easy even in the OPD basis as well.
Okay.
So
Sanjeev sir,
from
any
the bad disease, from we have faced 5 patients with ICHS grade 4, HLH very bad. Some of them developed CRS, CMV. Some of them developed also life-threatening coagulation problems requiring cryoprecipitate of 18 to 19, 2 times SDP and 2 times PRBC in a single day for 18 to 19 days as well. So from those parts, and then come the learning to anticipate things early. So now you don't have any trouble even with grade 3, grade 4 toxicities.
Okay, I think we have to learn more about this one to do CAR T on a OPD basis. Okay, sir.
Ah,
Sure, sir. We'll try to learn more and practice more with the CAR T. Sanjeev sir, any
Sir,
opinion?
yes. Sanjeev sir, please, some of your
I'm totally agree with Dr. Kunal. Just one comment. Please don't try OPD basis CAR T cell at present. Uh, because if everything is okay, no problem. But if problem occurs, you will be in
That's
problem.
difficult to, yeah,
So that is a
sure, sir.
very difficult situation. It is a medical legal thing. To I think try as much as these things in admission basis to avoid problem to yourself. That is my
Yes, sir.
take.
No, yeah, definitely,
Otherwise,
sir.
all
Currently,
complications are almost same. We are facing same thing.
Yes, actually, we used to admit the patient and keep them admitted for 28 days almost. Once the cytopenias recover, patient is a bit stable, then only we used to discharge. We have not yet gone for the OPD basis, but I think with practice we might do that in future.
For Western
Okay,
countries,
I
it's okay
think
to do the OPD basis these things, but in our setup where there is a high infectious complications, high infection rate, people are uneducated, not following instructions. We should not try this kind of things.
Yeah, so this
yes,
patient's
that's
husband is himself a doctor. He is a MD pharmacologist, and he was quite aware of all those situations. So he could take those risks, and he's staying just nearby to the hospital, adjacent to the safe place, and where they are following
I
it,
understand this patient must be a well educated and well counseled. That's why you
but
have
not
taken.
for
But
everyone. Yes,
yes, yes, doctors
agree.
are the worst patient.
that's
Yes,
true, sir.
yes.
Yeah, okay. So I think with this we have come to an end. That last slide, I think it's better, like sir has already said, better to get the patient with salvage therapy in remission and then consolidate the patient. That's all, I think. Thank you. Over to you, Dr. Tushar.
Thank you, Dr. Sadamani. It was a great session. Thank you to Sanjeev sir, Dr. Kunal for the wonderful inputs. And I think I would like we can take some questions from the audience. Um, One of the attendees have has asked, will the patient fit into autologous stem cell transplant because he is not responding to chemotherapy? So, Sanjeev sir, if you could if you could answer this question. So, I think when to go for a transplant, basically, they are asking that.
Basically, we can go for transplant if even there is a partial response. We doesn't need a absolute PET negativity for the autologous transplant to be considered. Salvage transplant can be done even in a partial response. Obviously, those patients who are PET negative prior to the transplant, they will have a better outcome compared to those who have PET positivity prior to the transplant.
Ri- Right, right. Thank you, sir. So, I guess one more question is there. Timing. Uh, f- I think it was answered. What should be the gap between the, I guess, salvage and CAR T when an immunotherapy is used? So the question is, even we had one question like if it's a CD20 based or CD19 based salvage. So is there any difference between the timing of a CAR T plant and the salvage therapy given? Any of the panelists?
So for CD20, like rituximab, we generally wait for at least 4 weeks. CD in general, what would be the minimum time is maybe a 2 weeks if it is utmost necessary. CD19, like blinatumomab, if you are targeting in BALL, then in some of the Western literature, they avoid doing CAR T due to escape chances. And even if you want to do that, we have done in the past as well. We have a data for that, and the CAR-T proved to be effective. At least 4 to 5 half-life should be completed, and maybe you can wait for 2 to 3 weeks with the Blina.
Right. I think that's very insightful. So I think we can conclude the session. So just on conclusion, I guess Professor Priyanka ma'am has to say something. Ma'am, please go ahead.
Yeah, this is a question to both Dr. Sanjeev and Dr. Kunal. We had a patient, in 2018, patient was high-grade B-cell lymphoma. Patient was apparently, she got 6 cycles of dose-adjusted EPOCH-R, double expressor, and double hit it was at that point. But after that, she relapsed in 2025. So approximately 6 to 7 years, the PFS was 6 to 7 years. But however, when we did it this time, the biopsy, it did not have CD19 and CD20 expression was also very low. It was almost absent if I say. But PAX5 was positive. So still they said that it was a relapse of this high-grade B-cell lymphoma. And the problem was she was also treated with Visolon for a prolonged time during this time of approximately 3 to 4 years because of some rheumatological disorders. And then she presented with a huge abdominal mass. So in this patient, when we started with the first RGDP, looking into the PFS was 4 to 5 years, we thought that it will be a chemosensitive disease only. But post 2 cycles also, the patient was not entering into remission, and after that we had to give her Pola. So what is your take regarding these patients? Suppose this patient now responded to Pola because we looked into CD79 and it was positive. But what about if the patient would have been like we are planning for a CAR T, patient not responding to Pola, trying to consolidate with CAR T, but autologous stem cell transplant with partial remission? What is your take regarding these patients?
I think it's a difficult case, definitely a aggressive one. And if CD19, CD20 expression is minimal, targeted options are not much. I will definitely like to add BTK inhibitor in patient as a part of treatment, along with polatuzumab or any other chemo. A combination of BTK inhibitor, chemotherapy, and polatuzumab will be my regimen of choice to bring her into remission, and then we can plan for either transplant. uh,
With the partial remission also, Sanjeev, will you go with a transplant or will you continue with the BTKI till she attains a complete response and then go
uh,
for a
I
transplant?
will try to make her PET negative prior to transplant.
Yeah, okay. Yeah, that is what we have done as of now. With Pola, at least he has responded. Now we are awaiting for a auto transplant. But I do not know how much because it was a chemo insensitive tumor. So how long will be her remission status post ASCT? That is a matter of concern. We have explained her though. Yeah, thank you.
Thank you.
Thank you. Thank you, esteemed faculty in participation. Thank you for joining tonight's insightful session. On behalf of IAIO Expert Insights, I extend my sincere gratitude to all our esteemed faculty for sharing their expertise, for making this session a success. A special note of gratitude once again to Dr. Tushar Pandey for his leadership as Program Director. All the participants will be receiving certificate 4 to 5 working days to your registered mail ID. I repeat, all the participants will be receiving certificate 4 to 5 working days to your registered mail ID. Have a wonderful evening, and we look forward to welcome you at our next IO event. Thank you once again for joining us. Have a wonderful evening. Thank you, sir. Thank you.
Thank you, Dr. Tushar. Thank you, Dr. Saudamini and Kunal and Dr. Sanjeev. Thank you so much. Thank you, Subhashri.
Thank you,
you,
ma'am.
ma'am. Thank you.
Thank you,
Thank
ma'am.
you.
Thank
Thank you,
you,
Dr.
Tushar.
Sanjeev and
Thank you,
Dr.
everyone.
Tushar and Dr. Sadam.
Thank you, everyone.
Good
Thank you,
night.
sir. Thank you.
Thank you everyone for your time.
Yeah,
Very
good night,
good
all.
night. Have a pleasant evening. Good night.
Good night,
Good
all.
night, all.